So signs and symptoms of pneumonia. Well, they vary because look at all the variables. Age. Does the patient already have another disease? Are they immobile? What's going on? So the type of organism, viral, bacterial, fungal, they all have different things. But classically, most of them you have the same kind of symptoms overall, especially if it's bacterial: fever, chills, shortness of breath, cough production, crackles, bronchial sounds. If you have viral pneumonia, remember viral is not bacterial, so the reason we get fevers are to fight the bacteria. Viral may be a low grade fever, but it won't be near as high as a bacterial fever. So these are your standard run of the mill patients that have had pneumonia, or if you've had pneumonia, you know it's that shortness of breath. It also makes you very tired. You are so tired, you just can't seem to get enough sleep. So if you've had it, you know what that shortness of breath means. Tests and treatment. Well, if we want to know what it is, we have to do a culture. So let's do cultures of the sputum. Hopefully that will grow out something and we'll give the right medication. We're not going to wait if it's emergent to get those cultures first, so we could use a broad spectrum until it grows out something that we need, and we can be more specific. Oxygen, if the patient is, if it's indicated, if they're in the hospital. So also they're going to be on a pulse ox, just to make sure their sats are up. These are going to be patients, not the run-of-the-mill young people, but elderly patients that already have heart failure, COPD, emphysema, bronchitis, or other diseases that would warrant them to be admitted to the hospital. Your WBCs obviously are going to be higher, usually about 15,000 with bands. Remember, bands are immature neutrophils. The body's trying to keep up with fighting the infection, so it starts using up all the neutrophils, and then it makes what's called bands. And you might have heard the phrase that the neutrophils or WBCs are shifting to the left. That means that they're making band immature cells. They have a lot of them, but they're too immature. They don't do any good. So that means you know that it's a really good infection, or a strong one, because the body can't keep up with the fight with the WBCs. Blood cultures, if that's part of it, if they think it's moved into bacteremia. So we're going to give antibiotic therapy. You want to have a lot of fluid. Fluid's going to help get the mucus out, help the coughing. These people need lots of rest, limit their activity. They will become short of breath. Antipyretics and analgesics are a big piece as well. So things that can happen when you have pneumonia are some of the other problems you're dealing with. For example, pleurisy. Pleurisy is the inflammation of the pleural, the surrounding pleural, can't think of the word of it right now. Anyway, pleurisy is the inflammation around the lungs. So when you breathe in, inspiration, it causes a rubbing sound. It's also very painful when you breathe in. So if somebody develops pleurisy while they have pneumonia, or if they just develop pleurisy from an infection, they're not going to want to take deep breaths, which will counter coughing and getting good, strong ventilation. Hopefully the pleurisy, if it comes along, the antibiotics will take care of that as well. You could have a pleural effusion. 40% of hospitalized patients have a pleural effusion. That's what ends up happening. They usually reabsorb in 1 to 2 weeks, and sometimes they have to aspirate the effusion through a thoracentesis. So we've talked about pericardiocentesis, abdominal encentesis, and now a thoracentesis. Atelectasis, another issue. You basically have collapsed airless alveoli. Those alveoli have collapsed. They're not moving any air. So consequently, you're decreasing the number of alveoli that can bring in oxygen and release carbon dioxide. Bacteremia, common for pneumococcal pneumonia, so that has to be watched very carefully. Empyema, it's less than 5 patients, but basically they form instead of a pocket of fluid in the effusion, they form an empyema. So sometimes these patients, they need to take that out by letting it drain out through a chest tube or an open surgical drainage of an empyema. So that is bacterial. So prevention outside the hospital. Well, we all know number one thing is a flu shot. Flu shot every 5 years, especially if you're in a risk group. What are the risk group? Who's in the risk group? Frequent hand washing, number one thing that can cut down any infection. Balanced diet, good rest, regular exercise, keep the lungs moving. Don't smoke, don't even be around secondhand smoke. That's going to stop that mucociliary mechanism. So prevention in the hospital. Well, why do we have patients use the IS? Why do we have them ambulate all the time? Why is it important to get up and move? Well, because we don't want them to develop pneumonia. If a patient has altered consciousness, we want them sitting up 30 to 45 degrees of the head of the bed up. We need to turn and reposition those patients every 2 hours if they're unconscious. Ambulate the patient. If patients receiving tube feedings, watch those residuals. Higher the residuals, the higher the risk the aspiration is going on. Do they have swallow issues? Hand hygiene. Just common things to prevent pneumonia.